All right, welcome everyone to another Movement Summit. This is part of our Movement Summit series, which is produced by the Council of State Governments Eastern Regional Conferences, Council on Communities of Color. Welcome to another installment, another conversation. We're having a Vaxx Chat today. Vaxx Chat, how do we have a better vaccination conversation? How do we do that better, particularly with vaccination rates still being very low? So we've brought this Vaxx Chat conversation to you in partnership with Healthcare Ready. Go to healthcareready.org for more information. In fact, let me go ahead and introduce the panelists, including Healthcare Ready's Executive Director, Dr. Nicolette Lewis-Saint, who's joining us here. And thanks so much, Nicolette, for partnering up with us on this very important conversation, very important panel we're having today. Also want to thank the Council on Communities of Color co-chair, Maryland State Delegate Jocelyn Pena-Melnick, who's joining us from the great state of Maryland. So thanks so much, Delegate, for your time and being on panel and helping us make this all possible. And Dr. Kevin Ahmad Jenkins is a social epidemiologist researcher at the University of Pennsylvania in Philadelphia. Good to see you too, Kevin. And so we'll go ahead and get this conversation going. Thank everyone else who's tuning in, who's listening in, watching us right now. And wanting to get more information on how to navigate this pandemic, but how to have this conversation about vaccines, about vaccine hesitancy and vaccine access. Still a lot of issues there. If you have questions or comments, you're welcome to start leaving them in the Zoom group chat now. I'll definitely share those throughout the course of this hour-long conversation as we're talking with the panelists, but please do that in your Zoom group chat. Please leave your various panels on mute and also leave your cameras off, but you can ask questions and leave comments in the Zoom group chat, which you see to the right of your screen right now. So, Delegate, I want to start with you and see what you're seeing in terms of vaccine access, vaccine distribution. What are you hearing from constituents? Well, first, are you still seeing problems with vaccine access and distribution? And what are you hearing from constituents as far as those problems are concerned?
So thank you for having me. It's really an honor to be with this distinguished panel, and I want to thank CSG for their advocacy and leadership. In Maryland, we have 24 jurisdictions, 23 counties in Baltimore City, and the county with the highest number of COVID-19 cases is gorgeous Prince George's County, which is an African-American county. It also has a large population of immigrants, Latino. And the zip code with the highest number of COVID-19 cases is 20783, which is the immigrant Latino community. So what we have, we learned that, and what we have been doing and putting pressure on the local, health department and on the state as well, the health department, is to make sure that we do not overemphasize the hesitancy, right? Because it diverts the attention away from policies that can fix the access and the structural problems. So we've been focusing on working with trusted community sources, right? The community trust, to make sure that we are flexible. So this is what we have done. We are going to the supermarkets. We are door knocking. I personally door knock on 1,200 doors about 3 weeks ago. And we have been holding vaccine clinics, not just Monday through Friday, but also extended hours and weekends. And we've been working with the churches, and we have to go to the soccer fields. We've been working with the supermarkets as well, right? So we have to make sure that there's no lack of access and that we make it comfortable for people, that we're flexible. We have to think outside the box as well. So we're being creative, and we have seen that the numbers in the Latino community are improving substantially, but there's still a lot of work and is to be done in the Black community as well. And that is what we're working on.
Delegate, real quick, before I go on to Nicolette and Kevin on this question too, to expound more on this, but I do agree with you. It's hard to have that conversation about vaccine hesitancy. There's still a little bit of it out there without overemphasizing it and then kind of prompting public health officials, policymakers to not work as hard or aggressively towards making sure everyone's as vaccinated as possible. But do you still hear that from constituents, like issues about like, okay, well, is this safe or not? Or, are you still hearing the circulation of like, disinformation myths that are circulating on social media? People still worried about that. Does that still become something of a problem for you? And
I think
how do
absolutely
you
all of the
combat that?
above. I hear people say, I want to wait. I want to wait. And I say, you're going to wait for what? The science is clear, right?
Yeah.
You're going to wait for what? What are you going to wait for? Because we have all those social determinants of health, right? The Black and brown community. So when we get the illness, a lot of us, we die, right? Because we have these underlying conditions. So there's still that, I want to wait. I want to wait a year, wait 2 years. And there's still a lot of work that needs to be done regarding the messaging to make sure that it's the right message, but also you have the right messenger delivering it. And we need the patience to make sure that we keep emphasizing it. Also, social media is putting out, there's some stuff out there that frankly it's not accurate. So we need to make sure that we check that as well. And that people are getting and are being careful and thoughtful where they get their information. You have to realize, where's the source? Who's the source? Who's the messenger? What is their intention behind it? So as a community, we have to empower ourselves because there's still a bit of hesitancy in wanting to wait as well. That is very true.
Yeah. Nicola, what is some of your, you've through a lot of polling and surveying that Healthcare Ready has done. What is that showing you? Real quick, let's just go over that, just top line. What is that showing you about why vaccinations is still low?
Sure. And thank you for this partnership and for helping us to continue to do this work of educating around COVID, but especially the vaccinations. So what we're seeing is that access and trust are still the biggest drivers of reluctance to get vaccinated. But it is important to make sure that we are taking those with equal weight, understanding that there are a number of individuals who are saying that they would get vaccinated, but they are having difficulty accessing the vaccine. And so it's important for us to make sure that, as Delegate Pena-Melnick has pointed out, we have to make sure that the message matches the needs of the community. So if the message is, hey, you should trust this vaccine, and individuals are saying, well, I have hesitations, but I do understand that I need to get vaccinated, but I can't go I don't know where to go. I don't have the ability to get to the pharmacy. I don't have the ability to take time off of work to be able to go get vaccinated. I'm concerned about what happens if I have an immune response and I can't call off of work for a day or so to rest. Those are access issues that have nothing to do with hesitancy. And if we're only messaging around trust the vaccine, trust the science, and not actually creating solutions that allow for those individuals to be able to get to a vaccine and to have that time that they may need to get vaccinated, then we've done a disservice.
Yeah. Kevin, what are you saying, kind of from your vantage point as a social epidemiologist, what do you think, and based on what you're hearing from the delegate and also from Dr. Lewis Saint, what do you think's going on here?
Well, I think a part of that message is also, what's wrong with y'all? Just hurry up, right? They're talking to us as if we're not allowed to say no, right? So I think we also have to remember that, one, when you ask a question, you have to know that sometimes the answer could be no. But two, if it is no, how do we respond in an authentic way? Yes, but how do we respond also with compassion? How do we respond by addressing the actual concerns versus just trying to belittle somebody because they may not understand, right? So I think a lot of times in this space, we look at access as a capital A. And within the work that we do, we look at access as a series of 7 small A's, right? So we see it as affordability. So there's an idea that sometimes I can't afford it, right? So that's a barrier to accessing something. We see accommodation we live in a moment where now everybody knows that gig economy is real, that a lot of people work hourly jobs. They don't get off at 5, 6 o'clock. They're getting off late. if you're already closed by the time I get off, you're not accommodating me. Therefore, you denied my access. When we think about it again, we think about availability, which is about the volume and supply of services. We should never miss in this opportunity, in this conversation, to talk about how even when we were trying to quote unquote do equity, we were still presenting inequity, where we were having these big places to do vaccine locations and vaccine sites, but they were literally in some cases done in Black and brown neighborhoods, but no Black and brown people were able to get in line.
Right.
So we have to remember that if we're going to try to do equity, in our process of doing it, we can't create inequity by how we're talking to people and how we're trying to actually prepare logistically to help the very people we claim that we want to help.
Yeah, Delegate, that's a very good point that Kevin is making. Like, people are going to say no. So, how do we prepare for when people say no? And, also, like, we have to have that conversation with people about, whatever reservations they may have. We got to be authentic and compassionate about how we approach this. So, how's that been? Has that been kind of a learning process for you and for your staff? As you're trying to, persuade, not only just persuade constituents, but also kind of take them by the hand and get them that kind of access that they need.
My staff and I are always authentic and compassionate in a very humble way, because that's just who we are, right? I mean, seriously, you can't be what you can, you are who you are. And I was taught with those values. So when they say no, I give them the science, I give them my experience, I give them and talk to them about the numbers and the cases and the calls I'm getting when people are in the ICU and they're now calling me, their delegate, to call the CEO of a hospital, to meet with the family, to dispute or, advocate for their loved one, because those are the calls I'm getting. Or when they can't pay for their funeral and I'm trying to find out, do you donate the body, or where can we find 10 grand for you? Or are you going to cremate the person? I mean, I'm keeping it real. These are the conversations that I have and that I am experiencing. And then at the end of the day, I'm not going to judge you. It is your decision. You have to live with it, as long as you allow me and you're open for me to give you the facts. And then it's up to you. I can't take it personally. This is not personally. At the end of the day, it's your individual choice, you and your family. But as a public official, I'm going to really work hard with respect to make sure you have the right information. And then all I ask that is, if you have all that information, that you consider it. And then at the end of the day, I can't blame you for whatever position you take, right? We must be respectful of each other because we come from different backgrounds. There's also a lot of distrust in our community, right? If we look at the past and the past experimentation in our Black community, right? And it takes time to build trust. So I agree, it requires patience and respect above all.
Nicola, it's Delegate makes a good point here, where it's like, at the end of the day, these are individuals making individual choices. And then, even there, however, you're making these really important individual decisions that have like huge like public consequences, right? Like, well,
yeah,
like my getting vaccinated or not, also has an impact, has an effect on what's happening to my household, my block, my whole community. And it's like, how do we reconcile that tension?
I started smirking because it's as if you knew the point that I wanted to make, or was kind of bouncing around in my mind. I think that's, if we're really looking at the pandemic, but also the way that just society works and the challenges that we've had to actually shift towards equity. A lot of it is rooted in the fact that while a lot of the actions that we take are personal, individually based actions, they have collective consequences, and we do not grapple with that. And so the vaccination process is truly no different. For me, as somebody who's been in the public health preparedness and response space, which, is a space where there's often an argument about how individuals prepare, how individuals do things, and treating it as an individual decision to prepare and saying, well, if you didn't prepare, it's your fault that things happened in this way. And I think that carries over here because it's difficult to have compassionate, really transformative conversations about the vaccination process without taking the whole of that experience and the whole of that reality, that it is both an individual decision and it has collective consequences. So, and we can't exist without both of those. And so understanding the root of the why you are taking this collective decision and the impact of those consequences, not just for you, but for the collective, is a necessary part of the conversation. But we've turned it into this binary thing of almost either you're getting vaccinated or you're on the wrong side of the pandemic, or you're getting vaccinated because you're smart and you trust science, or you're not getting vaccinated because you just don't know any better. And that's not it. That's not the binary that we're in, and that's not where we need to exist. But part of it is we do have to be honest about the fact that we are connected. And the way we get out of this pandemic, the way we address our inequities socially, medically, otherwise, is as a collective. And I just don't think we've managed to turn that corner in our conversations. And I think that's really our primary barrier right now. If somebody says, I'd want to do it, but I have a hesitation about X. I so often when we're having these conversations and we talk to people about why they're hesitant, we rarely ask why. They say, I don't want to do it. And we say, well, here's why you should. And it's like, well, I could give you a million reasons. And it goes back to what we've learned in our poll and the work that Healthcare Ready's been doing. But if I don't know your why, then the reasons I give you may not address your why at all.
Kevin, go to that, because it's we have to get out. What Nicolette is saying, we've got to get out of this pandemic as a collective. But like, how do we get there? And that's especially true. That's supremely important for Black and Brown populations. Like, we operate collectively, spiritually, emotionally, politically. I mean, we really, our survival hinges on us always acting or thinking, in a collective manner at times, or mobilizing in a collective manner. That's more of a sort of imperative for like Black and Brown populations than it is for other demographic groups. So speak to that.
One of the biggest things in that A continuum I was just given earlier, there's one A of accountability that matters, because even as we are creating such systems, how are we holding people accountable? We know in Philadelphia, the debacle that happened with the vaccine rollout in Philly. So it's hard to ask us to yet again trust blindly. And yet, even in that moment, you let us down. You trusted our lives with a 22, 23-year-old kid because he did a nice presentation, right? When we talk about the idea of an A of awareness being a piece of access, the ability to communicate to us, right? And just have that conversation to say, hey, this is what we need to talk about. Vaccines, I get all the issues. When you started going on to the news, notice how the news, when the vaccines first rolled out, how they started talking about it. And then notice what happened over time when the data came in. When the data came in, they were like, why are so many Black and Brown people not getting the vaccine? And then immediately the stories turned to the hesitancy, and never asked why. It never really asked why. It tapped back to Henrietta Lacks. They try to go back to all of the Tuskegee experiment. Let me just say this. We don't have to go back to Henrietta Lacks, Tuskegee, or any other kind of historical medical moment. All we really have to do is look at 2020. So what we have to also remember is there was an election that happened at a federal level where it was very weird, right? We didn't understand what was going on. I'll say that to be nice. But then we moved into the new administration, and I'm going to be honest, the communication really didn't get better. Right? So even if we want to step outside of our political corners to really, again, have another serious conversation, if we don't want our communication about the vaccine to people of color, not everybody, but to us, if you're not willing to have that conversation to us, then that also is presenting the barrier of a lack of access yet again, right? Just by not wanting to ask why. That's a problem.
Yeah. Delegate, I mean, do you have these conversations with public health officials, with other policymakers about like the accountability? Because Kevin is very much right. He's very correct here in that we just assume that, well, one, if we do have trust conversations, we talk about the history, Henrietta Lacks or Tuskegee. It's like, okay, well, just get over it. That happened a long time ago. We're here in 2021 now. You need to get vaccinated. But then, no, we were going through this. We've been going through this for quite a long time, up to just right now. And so I'm wondering, I mean, are public health officials, are people in like your county, in your district, who have to do, who are doing the outreach, administering the vaccine, do they understand this? Do they understand the various dimensions of this conversation, how important trust and accountability is?
If they did not understand it, they understand it now. I can tell you that. And Colette was laughing because, look, it's what I've been and my colleagues really focusing on and holding the Department of Health, to hold their feet to the fire. We have an oversight committee that the legislature created. And although we're not in session, they meet every Monday and they bring the Secretary of Health and they go through the numbers and they go through the different counties. And us, people of color, it is on us when we're in a room not to just warm that chair, right? You bring a certain experience as a person of color, as a woman, whatever you are, to be able to share it and to speak up in that room and to make sure that we are present, that we're not an afterthought. And if they want to focus on hesitancy, we've been refocusing them and saying, wait a second, let's not pay so much. Okay, you're right, there's some hesitancy here, but there's also some access and structural problems. Are you going to the churches? Are you working with the trusted sources, people that are the voice that the community feels comfortable? Are you going to the supermarkets? Do you have ads on the Black stations, the Latino stations? What are you doing? Are you door knocking? Do you have people that look like us at the doors? So those are the questions that myself and my colleagues are asking through that oversight committee to the Department of Health and through very emails that you don't see or read about, that we're constantly, we're like a pain. And I mean, we're just really, we are not shy and we're very assertive regarding that. And I think that is why they're doing what they're doing now, where they're being creative.
Nicola, what do you think is the ideal strategy or model? If you had to package it into a formula, right? Like, hey, these are the 3-4 steps that you as a public health official, or we as a community, or you as an elected official like Delegate Pena Melnick here, have to take. Like, what's that formula? What's that like perfect formula or perfect strategy for making this a successful outreach campaign and making sure as many people are vaccinated as possible?
So based on where we are today, or do I get to like blow the whole thing up and rebuild? Just
you can blow the whole thing up and rebuild. I love doing stuff like that. I love deconstructing. Right?
Yeah. So I think if we blew the whole thing up and built what we needed to build, I think it starts with a more coherent national strategy, not a federalized strategy. So to me, if we're going to really blow it up and do it right, we should have a unified global voice on how we are taking. Let me step even further back. This is an emerging infectious disease outbreak, which means information is going to change over time. We are going to learn new things as we go. The things that make an emerging infectious disease outbreak tricky are partially the dynamism of the event itself. And so being able to make sure that we are cohesive in our communication all the way to how we manage expectations and understanding that public health communication changing or shifting is a result of having different information at that point in time, not a failure of previous work. And so if we're going to really blow the whole thing up and start over, I think where we start is from a place of making sure that with our multilateral organizations, with the UN, with the WHO and the health ministries for our nations, that we're cohesive about how that science is getting pushed out, what scientists are going to be able to pull together, and how that translates into the evolving public health message. And then for our country, then it becomes a matter of how do we create a national strategy on COVID? Everything from how to prevent yourself from getting it, to include vaccines. If you get it, this is what you should do, to include the therapeutics that are in every state that we're not talking about while we still have COVID outbreaks, and then how we move on past it. And that, I think, takes the burden from the delegate Pena Melnick's, who there really aren't many of, the local health departments who are doing the work of the nation, trying to figure out how to build a message, galvanize people, and also ensure trust, right? Part of the reason we would need to rebuild it is because the CDC message right now, it has to get filtered and translated through the state, through the locals, to the communities, and we don't have time for that.
Yeah. Hey, so on this question, Kevin, it's a very good point from Nicolette, but I mean, I found myself, consumed on the program that I was on just before I jumped on this panel, my program on WRD, having to actively debunk, some claim, someone called in, trying to push a particular drug that has been already fact checked rigorously. And but when I was saying, well, hey, the World Health Organization, the FDA, NIH, all these I had all these sources who've already said, hey, listen, this has not been rigorously examined. It's from low quality research. People are like, well, why trust the government? Like, we don't trust, it's like, how do we so we want those organizations, we want to be able to have that unified, cohesive government, international, national response with the government leading, but then we have such low confidence in government these days. People really don't trust information coming from government agencies, especially in Black and Brown communities. That's an issue for a lot, obviously for a lot of good reason. But how do we tackle that, Kevin, you think?
Well, again, it starts with our, if you will, peacetime efforts. It's really hard to build trust when the war is going on. Right? It's really hard to build trust when when like life's coming at you and you're like, hey, trust me. It's like, hey, hold up. I'm just trying to make it to the next moment, right? So I think we have to really also be focused on making sure that, yes, we're cohesively doing those things. I was thinking of these C's as you were talking, Nicolette. And one of the other C's that's popping in my mind is credibility, right? How do do you have the credibility to speak about this? Even with my PhD, I do not get on any program telling somebody what they should or should not be doing, because I am not qualified to say that personally, to tell somebody with certain things, because I know what time it is, right? There is a point of qualification when it comes to the personal experience, right? And I think personally that if we start going back, I mean, we all remember Calvin from the McDonald's commercials in the 90s, I hope, but they told us a story about Calvin. They explained that Calvin said he's going to run this store one day. And they told us the story, and we were able to follow his career all the way through. Right. And I think in these moments, what's really hurting us is we're no longer being told stories in our campaigning. They're not making us connect. Delegate Pena Melnick is the point. She's the story. When she's knocking on that door, she can talk to people in a different way. Why don't we doggone do our public health stuff around her knocking on that door? Let's follow her. And I know you don't like that type of stuff, but I want people to know that we can tell a story and talk to our people the way we talk to our people. Because my issue is not that, listen, sometimes we do have to talk to my aunt is one of those who, she's in her late 80s. She's good. She's like, I could care less. Like, if the good Lord take me, I'm gone. That's all right. right? So she doesn't want the vaccine. That's a hard conversation. But I've had other relatives that I'm like fighting and trying to just convince them. And finally, you know what it was? It was the story, not the numbers. And it wasn't my story. It was saying, Auntie, we ain't had Thanksgiving this year. You know that? We did not have Thanksgiving, and I did not get to hug your neck. Can you imagine the only thing between me hugging you and getting to the good mac and cheese this year is going to be a vaccine? Can we do this? Right? It took her a while because you're not in that moment trying to twist her arm to make a decision. She made that decision later. She ended up getting it. But it was like, I knew I had to drop that seed so she understood I cared, but I also knew the numbers might not matter to her. So with the people that the numbers don't matter, the story has to matter. But remember, don't choose stories that are so individualistic. They'll just say, oh, that's a, you know, as in science, we say that's an N of 1, right? So that's just not a big enough sample size. We got to connect with people, and let's just keep bringing that rag out to figure out how to be authentic, but really just letting the people who do the thing, right?
You're just joining us right now for our Vaxx Chat. How do we have a better vaccine conversation? And this is being brought to you by the Council of State Governments Eastern Regional Conference, Council on Communities of Color, CSG-ERC.org. For more information on the Council of Communities of Color, the work we do, also being produced by the bnote.com and moderated by yours truly. I'm Charles Ellison, by the way, publisher of the bnote.com, and also on, I don't think I introduced myself. Oh, by the way, hi there. Also, that's what you get, you know, from rushing from a radio program to another, you know, everything just moves when life comes at you. But also normally host, executive producer of Reality Check on WURD, which is at wordradio.com and on Word TV, publisher of the bnote, THEBE-note.com. We're also doing this in partnership with Healthcare Ready. So go to healthcareready.org for more information. I did have a question here in the Zoom, and folks, if you're now watching us, into which some of you are watching us and tuning in, you can give us some comments, show us questions in the Zoom group chat to the right of your screen. So do that now. And while we ask the next questions, Delegate, there is a question here from CSG East. There is also the anger factor. I'm going to start with the delegate first on this. There is also the anger factor after having been mistreated by healthcare systems. How do we reach them?
I think that you do what Nicolette said. You talk about the experience, right? You ask what happened. You basically say, okay, that happened. Can we try something new? Can we find maybe someone, a doctor of color, you know, someone that you can feel comfortable with, right? Can we go to the right institution? Can you, and I've done that a lot, where you walk the person through it, but first you must acknowledge what happened, have some, as Kevin said, some empathy, and then move on to try to help respectfully, right? As well, the way you present the information, but you must acknowledge it and then inform them. I don't like to say educate, okay? Inform them of the different options and the different providers. Like in Maryland, we just passed a bill that I put in that basically requires implicit bias training for all healthcare providers, you know? And we make sure that we also pass a bill that encourages more recruitment of providers of color, right? Institutions that reflect us as well, and make sure that the institutions are opening in our neighborhoods as well, you know? So I think that it's a conversation like any other that you should have. First, you start by acknowledging what happened.
Yeah, and you know, that's important too, because I think, you know, during the course of this pandemic, right, Nicolette, we immediately had to rely, we had no choice. We had to rely on our first responders and our medical professionals. But that one of the conversations that was left out of that moment was how, you know, we as Black communities, as Brown, Indigenous communities, we've been dealing with medical racism for quite a long time, through generations. And it's not just like Kevin said, or it's not just Henrietta Lacks or Tuskegee either. I mean, this is something that we routinely, daily have to face with. And that was really, it is something we really needed to address in the middle of pandemic too. Some people thought that conversation was inappropriate. I don't think it was. And so, but there is that anger and also that fear of having to go into a hospital knowing you've had this experience recently, and then you have no other choice but to rely on people in these medical systems. And I wonder if, like, medical professionals, if they really are aware of that, if they're, starting to be a lot more empathetic to that discourse, to that dialogue around medical racism. And like, how the delegate just said, that's the kind of legislation we need, that kind of bias training in medical institutions. Go ahead, Nicolette, I'll start with you and then to Kevin.
Sure. So I think you got to unpack that a bit, because I think the conversation happened in pockets. But I think how we, again, if it's a national strategy, how we address it and own it collectively goes a long way. You shouldn't have to be plugged into the right discussions to have visibility on those conversations. But I think there's another way to look at this, and I think it's about the outcome of medical mistreatment, which is trauma. So we're using fear to talk about the driver, but truly the outcome is trauma. And if you're thinking about how we could and should be communicating critical information to populations, individuals who've been traumatized, I think all of a sudden there's a little bit of a light bulb that goes off that says, I can't just speak to you with the facts. I have to be able to communicate in a way that addresses your trauma.
Yeah.
A lot of the conversation about medical racism and just the history of medical mistreatment, which takes on a lot of different vantage points. It happens at some points in some schools, some institutions more than others. As somebody who was trained in a medical school that kind of touched on it in part because I trained at the school where Henrietta Lax's cells were first harvested, that was a conversation that happened. But what it looks like to think about not just the history, but how you move through that as a medical professional and as a medical scientist going forward, it's something we're still figuring out. So I think there's a difference between, how we teach something that is known and is historical context or scientific information versus how do we teach dynamics and phenomena that we have to collectively embody and move through. And I don't think we've gotten there yet. But I think the other part, and this is the part that's concerned me the most, even as somebody who's been out there doing a lot of talking about COVID throughout the entire pandemic, we've replaced conversations about medical mistrust with tokenism in ways that I think are very problematic. So just because I am a Black woman and a medical scientist, those are not the reasons that I should be the person talking about COVID, right? And there's been so much of, trust me, I'm Black. Trust me, I look like you. Trust me, I'm from your neighborhood, which is not the reason to trust what I'm saying there, and I think Kevin was speaking to it earlier brilliantly about the idea that we know what we know and we know what we don't, and we speak to that, but there's a level of credibility that should be afforded. And some of that is from the individual end, but some of that is from technical skill and training. And for me, I'm an infectious disease pharmacologist. That's why I'm talking about COVID. It's not because of the tokenism that is going into a lot of these conversations. And so I just want to parse that out, because I think there have been places where we've been a little lazy in our collective conversation, and we've been looking for a Black person to speak to Black people about COVID rather than the right person who understands the context and the message.
Yeah,
because they've been shooting in the
go
gym.
ahead, Kevin.
Oh my God, thank you for saying it, because that's what my problem is. Like the folks like you, Nicolette, you've been shooting in the gym. You've been shooting in the gym. Like, you are the person we have been waiting on. That sister Corbett, that was on, she's the one who developed the doggone vaccine, right? So what I'm saying is that ultimately, we also have a nuance we have to confront. And that's what this pandemic did for me. It made me realize that even from my perch with the shield that I can lean on, being that of the University of Pennsylvania and my credentials and all those other things, but I had to know in this moment, this ain't my lane, right? This is not my lane, but I know those brilliant people who can do this. So let me bring them to the table. And I think that's the difference. The difference is those people who have the opportunity to welcome those true experts into the room, they don't, because it becomes an ego issue because they want to be in the way. They want to stand and be seen. So I think something that when we talk about trust, 1 in 4 African Americans who access the healthcare system experience racism, right? 1 in 4 who show up experience racism. What we also know is that 80% of adult African Americans and roughly about 82% of those who identify as Latino have experienced racism as an adult at least once. What we know is that Black and brown children, roughly 82%, almost 83% of Black and brown children between the ages of 13 to about 16 have also experienced racism. What we do work on is talking about both the pathophysiology of racism. So how does racism get into your body? How does racism change or modify your health care? And most importantly, how does racism or the presence of this trauma of racism impact how you make healthcare decisions, right? That's the work we do. And our answer to that is a model that, Nicolette, I know you'll love, and I can't wait to roll it out. It's called the racism-focused trauma-informed care approach. We are treating racism as a trauma. We are treating it as a trauma so that we can, 1, show the pathophysiology or the health effects. We can show the healthcare and healthcare decision-making effects of racism. Because if I think you're racist, I'm not going to talk to you, right? Why would I go out on a date with somebody I don't like? Right? So it's just amazing how we keep making it to where we as Black folk and brown folk, we have to accept lesser service no matter what. And what we were hearing is that upon presentation for so many folks that were going to get the vaccine, they were still mistreated, right? Even though they left, they got the sticker that said, I'm vaccinated, they had the Band-Aid on their arm, they still had a bad experience. Right? We've got to make a decision that we mean more to each other, that we protect each other's process, because equity is not an outcome, it's a process. And if we're not ensuring the process is equitable, why is it so shocking when the outcome is not?
Yeah. So there's a question from Shirley Gerard, who is asking about healthcare workers. She's very concerned about healthcare workers and many of them not vaccinated in many instances. And so, Delegate, I'll go with you on this question. I'll start with you on it. What are your thoughts on that? Is that something you're seeing? And especially you're in the position of being a policymaker, do we need to, she's asking about mandating vaccines. Is that something that we perhaps, one thing that I do see though, folks are not going to be able to get into schools. They're not going to be able to travel on planes or get into certain public spaces or get certain jobs if they don't get vaccinated. That's obviously going to start some problems.
Well, a lot of the schools in Maryland are already mandating that if you're coming back to campus in September, you have to be vaccinated. A lot of our hospitals in Maryland, I know and other hospitals have already required that you be vaccinated. So, we left it up to the individual systems and organizations to make that decision rather than us mandate it from the General Assembly, because you have to look at your organization, you have to look at your employees, and you can't really just come right out and say you're going to do it, right? We talked about this 30 minutes ago, what if the person says no? You have to say, but why are you saying no? And how can we compromise here? And that is what a lot of the hospitals and organizations are doing now. And we as a General Assembly have made the decision to allow each individual system and company to make that decision so far.
Yeah. Go ahead, Dr. Lewis Saint. Yeah, any thoughts on that? Like as far as vaccine mandates, or kind of low-key mandates, which, on one hand, we don't want to see a situation here where it's like these forced, perceived to be tyrannical mandates to take a certain vaccine. But on the other hand, this is what we grew up with, right? You need to get your shots before you go into a school. And so it's interesting to watch how what was once acceptable back then, when we were all growing up, now it's just so difficult for people to accept.
So you also have to bear with me. I've been doing this for 18 months, so my tact is a little, you know, to need of a refresh. But I think that's a part of it to me is there are levels to this, right? So like if we're thinking about where your personal liberties end, they end really once you leave your personal space, your personal property, right? That's not my rule. That's the way that America has worked. And so when you're thinking about how we've managed infectious diseases and things that can cause collective harm, vaccinations have been, they're the reason that I am 36, right? So if we're thinking about it from the vantage point of like how they work, I wouldn't have lived past 13 if I was lucky, right? So vaccinations have gotten us to this point. So the concept that certain vaccinations have been mandatory, public school kid, right? Like, yes, vaccinations were mandatory for me to be able to go to school. Vaccinations were mandatory when I got on a college campus. Vaccinations have been mandatory as somebody who's worked in a hospital. This is not the only vaccination that was mandatory. And if you did not agree to take that vaccination or to get that routine testing, the flu vaccine is just an example. There were consequences. And it wasn't just about being tyrannical, it was about the perceived public health and medical risk to you, as well as to the people around you if you do not have immunoprotection. So these concepts are really decades old. The idea that we rely on vaccines and vaccinations to keep us alive is the reason we can be fully functioning adults. And I'm not even saying that to be funny, but like we really think about the number of vaccines from birth to adulthood that are the reason that you are alive. Yeah. So the concept of vaccines is not the issue here. I think the root of it is, how do we feel about being forced? The word mandatory, I think, actually elicits a set of responses that are more about that mandate than the actual vaccine. And then the questions of what are we still learning about the vaccine that would give uncertainty as it relates to the mandate. So I think, again, that's another thing that needs to be parsed, because mandated vaccinations, those are not new concepts. And I could totally understand in a healthcare environment, because of the related risk to being in a hospital system where you are more likely to be in the presence of someone who's contracted COVID. You're more likely to be in the presence of someone with shingles or the flu, or, you know, pick your infectious disease. And if there's an opportunity for you to have immunoprotection so that you're not just not protecting yourself, but not taking it back out into the community, that's a reasonable concept. But again, that may not be the crux of the issue.
Well, you know, Kevin, and I know we've got a short time to go before we end this panel. It's been there's so much there, right? I mean, so much we've been unpacking, and we could go on for a longer time. But I want to make sure I'm respecting everyone's time and schedules. Kevin, I do want to ask this question. I'm asking this as a media professional myself. How should media be handling this conversation, right? Because I feel like, especially as someone who does radio every day, I feel like in fact, I always do this as just sort of a standard practice. I have my talking points, because I know the question at some point is going to come up from either a listener or I'm going to have an expert on. I have my kind of basic list of vaccine pandemic talking points, just fact. I've already done the research. I fact checked things. I've got some of the top myths I've heard about circulating that have been fact checked by all these major credible journalistic institutions. So I feel like every media outlet should be doing this, but I've seen instances where there's been some really irresponsible broadcasting conversations. And so it's like, how should we as media professionals be navigating in a time like this? Because we're responsible for people's lives too. We got to make sure we put the right information out there.
I just fundamentally believe if you're Black and brown media, you shouldn't be talking about hesitancy. I think we should be talking about how to get people to do things, how to make a more comprehensive campaign. But I spoke to a reporter from a diverse media outlet, I'll say it that way. And I said that. Like this reporter called me and was like trying to basically get me to say something just terribly negative about why Black folks won't do this because of Henrietta Lacks or something. And I'm like, we can go back 2 weeks ago to tell you about mistreatment in medicine, right? But I think we also have to remember as media, you got to remember too that, you know, we're not speaking about this because it's so politically taboo to talk about it. But there's been somebody lying for about 4 years. Right? Seriously. And, you know, I don't have a dog in the fight. I say it, right? We've had to deal with the inconsistent and untrue set of messaging anyway. So then when you run the package about a vaccine, and then the package that comes right after the vaccine and why we should get it is then the everything's a lie package. That's next. Right, I'm going state by state. We were in Missouri. I just did Michigan last week. Like I'm going to these states that were very severely impacted by COVID, and they're still having the same problem because the politics became personal. The things that was just simply political language at one point in life, that really became what we all needed to hear as truth. So now we're here today putting all the onus on you as media or on Delegate Pena or on our physicians to try to deal with something that at a federal level was so irresponsible. It's a conversation that's going to take decades to rebuild the trust of our communities. Forget color. It's going to take decades for all of us to come back together. But then on top of that, we have to deal with the racism that came specifically from our political spaces. And now we're really trying to deal with it in a whole different way. So that's where I see us going as media. We have to also have conversations that are honest. And you can't run, like even in how you budget the time and budget the stories, to have a vaccine story and then run right after that, everything's a lie story, you're contradicting yourself. Right. And this isn't, you know, the quality that you put out, Charles, has nothing to do with this, has nothing to do with you. This is about the fact that when we get to our quote unquote mainstream media, they don't care how they talk to us. No. They don't care how our communities are talked to or represented, but we've got to force that issue.
Real quick, I know we got to wrap up in a couple of minutes. Nicolette, get your last thoughts on that. And Delegate, I'm going to have you get the last word. But Nicolette, like, how should media be having that conversation?
Totally agree. I think part of what we should be doing in these conversations is challenging our assumptions. So the reason we did that poll, for example, was to say, you know, we keep saying it's hesitancy, but what is it really? What are people saying today? So let's challenge the assumptions, but also that framing. I never thought about it that way, Dr. Jenkins, but if you're thinking about the framing of let's have this informative conversation, and then right on the heels of that, we go right into, let me tell you about the latest lie. Well, there's a compounding effect there that I never, you know, fully appreciated, but I could imagine, you know, especially after the last 4 years, would play a huge role in someone's comfort.
Mm-hmm. Delegate, yeah, your thoughts too on, like, you know, especially how, well, you know, actually, I just want, let me throw this question in here and I'll let you get the last word. Kelvin Chapman is asking or commenting, great call, hands down. My church is in Baltimore City, Still Meadow. We provide testing for COVID and host a FEMA's mobile vaccine program. People will show up for the free food giveaway and testing, but bypass COVID vaccination. How can we motivate minorities to take the lead to demand better care and educate themselves on the benefits of various vaccines? Obviously, we've been having, thank you for sharing that, Kelvin. We appreciate that. And obviously, we've been having that conversation, addressing that. But your final words from you, Delegate, on what Kelvin's saying on that media question and just this conversation in general as we wrap this panel.
I think that we have to report responsibly, fact check everything, make sure again that the people that are reporting look like all of us as well. Make sure that the people that are reporting go into neighborhoods that they may not be comfortable and talk to real people and ask the why. And that's important. And bring the proper experts, not just because you look like me, you know, you're all of a sudden an expert. So it has to be well balanced. That's really important. And we must continue to have the conversation until everyone has the right information based on science.
Exactly. You get the last word, Delegate Jocelyn Pena-Melnick, who is representing parts of Prince George's and Montgomery County, I believe, in the DC.
Prince George's and Anne Arundel.
Oh, Anne Arundel. Oh, it's Anne Arundel too, right? Okay. Sorry about that.
Okay.
It's Prince George's and Anne Arundel, not Montgomery.
Yes.
Okay, got it. Yeah, thank you for that. And so more information on her, she can go to @JPena-Melnick on social media, on Twitter. If you'd like to get more information, keep track of what the delegate's up to. Also, Dr. Nicolette Lewis-Saint, Executive Director of Healthcare Ready. Go to healthcareready.org for more there. And Dr. Kevin Ahmad Jenkins, social epidemiologist at the University of Penn. For Dr. Nicolette Lewis-Saint, @Dr. N. Lewis-Saint, and Kevin Ahmad Jenkins is @KJ Answers. I'm Charles Ellison. I've been your moderator, your host for this Vaxx Chat discussion. We're going to have many more. This is being presented by the Council of State Governments, Council on Communities of Color, of which the delegate is a co-chair. I'll always appreciate her collaboration and her partnership and good work and insights. And also the bnote.com, of which I'm a publisher. And we did this in conjunction in partnership with Healthcare Ready, more at healthcareready.org, some great information and some insights, some critical information you need there to get you through this pandemic. I'm Charles Ellison. I also want to give a good shout out and thanks to the Council on Communities of Color Director, Debbie Ann Page. She's around there somewhere. So these movement summits, which started out as micro summits last year, would not be possible without Debbie Ann Page. So she's definitely, she's like the whiz. She's behind the scenes. She's getting it done. So we want to thank her, as always, for allowing us to present these very critical conversations to you. All right, everyone, I want you to be safe out there, and we'll see you next time.